Hello. Oh, hello. Welcome to the symposium for the 50th anniversary of the center formerly known as the Health Services Research and Development Center, now known as the Center for Health Services and Outcomes Research. This is a symposium which is in many ways the centerpiece for activities that we are having this fall and in the spring to celebrate our semi-centennial. I should say that I'm Albert Wu. Some of you may not know me. I'm director of the center, and if you're dying to follow one more person on Twitter, I'm @WithYou, Dr. Wu. Some thanks are due for organizing this event. In particular, Jill Marsteller has chaired our committee to organize and pull things together. It's not actually as if organizing symposia is on anyone's official job list. So all of the people who've helped out have really made a little bit of a sacrifice to participate, though it's been fun, and delving into the history and perhaps what's coming up has been rewarding. So anyway, Mary is sitting outside. Julia is also sitting outside. Julia is sitting with us now. Emmanuel Drabo, Vadim, who's our ringmaster. Lily Engineer is here. There she is. Caitlin couldn't make it, but Caitlin helped with a lot of our program materials. Manny Akeda and Skinner is our archivist and historian. Renee Wilson is in the red hair back there, and Brenda Zakarko is taking care of everything social. We had particular help and are having help today for this particular symposium, and there are other events which will be happening later this fall. So I think our whole idea for this symposium is looking back at some of the history and some of the origins of the center. And we're doing this not just to reminisce, but to be able to move ahead. Some of the themes for this symposium, I think, are sort of figuring out what our direction should be, noting what's been done in the past, and helping that inform our direction in the future. The group has gone from being pretty small, and you will see and hear about this, and quite cohesive, everyone working on the same thing, to being quite a large group and with a diverse group of interests. And this is something which we are happy about, but are also wrestling with. We've gone sort of from a niche idea or a niche set of skills to a set of skills that are increasingly popular in the world, and that's rewarding. We're going to have a very interesting discussion about future trends, and then we would like the group to help us think about future directions. For those of you who are not so familiar, the Center for Health Services and Outcomes Research, we would like to persuade people to pronounce this Cheshire, and sometimes people do, as in Cheshire Cat, if that helps you in any way. Our vision is to drive optimal health and healthcare through research, and our mission is to conduct research and develop innovations in policies and practices that help people and institutions achieve the best health outcomes they could through the delivery of high-quality, patient-centered, safe, and efficient care. And public health practice. We're not just about clinical care. I'd invite you to visit our website. There are these panes, our panels are a lot of the research that's going on, but we're mostly focusing these days on the quality and the value of care, on patient safety as a subset of that, and on patient-centered outcomes, both measurement and trying to evaluate interventions. We also function as a little bit of a home away from home for some of our colleagues who are not in the School of Public Health. We're very fortunate to have Colleen Barry here, who's the chairman of HPM, chairperson of HPM, and the center lives in the department. However, many of our members and affiliated members are in other departments in the school and in fact elsewhere in the university. And we, many of them have said, you know, you're our real home, where some of us are PhDs in clinical departments, and much of the work you do is what we are trained to do and where our hearts really lie. So, so thank you for being that home. And one of our secret agendas is to perhaps lure some of you to work more with us in the future, even if you sit elsewhere. You all have the program. We're going to be treated to a PowerPoint video about Cheshire over time. We're going to then hear from Laura Morlock, who has been with us, with the center for almost from the beginning, about some of the foundations of the organization. We're going to get a series of talks from Sheila West, David Celentano, David Salkever, and Kevin Frick, many of whom are now elsewhere. But in fact, just about all of you are not sort of sitting in HPM anymore, but were members of the center at various formative periods. There's lunch at 1:30 and an icebreaker. That's going to be followed by a keynote from Jonathan Peck, a futurist who's going to talk about trends and future developments. And then we're going to try to have a discussion about what all of this, looking back and thinking forward, should steer us to be doing. So with that, I'm going to sit down and pass off to Ann Skinner, who's been the maestro of this, and archivist for this next presentation.
This is a joint effort. Maniketa has done the visuals on this, and the historical parts from me. We'd like to actually start with a history lesson. I'm a little too short for this.
Dear friends,
it's about the founding of the Health Services Research and Development Center in 1969, through the transition to Cheshire in 2011 to today. This presentation covers the decades since 1969 and tries to follow threads of research through that 50-year period, with branches off. By no means do we cover everything that the center has done. With 50 years, we've got zillions of investigators and hundreds of projects. These are just a flavor, so a small selection of what we have. Many of you will not recognize the names or the projects that we're talking about because they are old. But I think you will see that by and large we've maintained a focus on topics that were laid out in 1969. Focus on primary care, which we can consider these definitions loose, but primary care, quality of care, information systems applications, development and applications, health manpower, and health financing. We've been doing research in those areas since the get-go. We hope you appreciate the legacy available to you today as you continue your work in health services research. So Manny, take it away.
Right. I'm not actually going to say anything. I'm just going to hit next slide.
dear friends, we come together today to celebrate 50 years of health services research at Johns Hopkins, first through the Health Services Research and Development Center, and then known as the Center for Health Services and Outcomes Research. Once upon a time, A very long time ago, back when the Bloomberg School of Public Health was still known as the School of Hygiene. We lived in an era that predates the invention of the World Wide Web. That means no Google, no Internet, no Alexa, no Siri, no Amazon Prime 2-day shipping. How did we even survive? On a more serious note, the 1960s were formative and filled with poignant political and cultural significance. This era is marked by passage of Medicare and Medicaid. The 1960s are also indicative of the Civil Rights Movement, which affected cities nationwide, including Baltimore. The progress made from this movement did not come without a price. In the wake of this political and cultural upheaval, the university decided it was time to focus on Baltimore's healthcare needs, with an emphasis on evaluation of health services structures and outcomes. In 1967, Kerr White and Philip Bonnet submitted a proposal for a Health Services Research Center to the university. In 1968, the Columbia Medical Plan and East Baltimore Medical Plan were initiated. They subsequently served as a locus for research and evaluation by the Health Services Research and Development Center. Here's a screenshot of the first 5-year core grant proposal the center submitted and was awarded in 1969. In July of 1969, Malcolm Peterson was named the first director of the Health Services Research and Development Center. Health Services Research is the multidisciplinary field of scientific investigation that studies how social factors, financing systems, organizational structures and processes, health technologies, and personal behaviors affect access to healthcare, the quality and cost of healthcare, and ultimately, our health and well-being. Its research domains are individuals, families, organizations, institutions, communities, and populations.
Johns Hopkins has been involved in health services research for a long time, and one of the exciting things about being at Johns Hopkins was that history of people who have really broken new ground. We have a Department of Medical Care and Hospitals, which dated back into the early 60s. And the Health Services Research Center, where I went to work in '72, was started in 1969 as part of a university-wide effort to improve primary care, demonstrate new ways to deliver primary care. And you hear that story today.
The center's main research domains were primary care, quality of care, information system design, health manpower, and financing. Projects in these domains were funded by the Carnegie Foundation, Rockefeller Foundation, Commonwealth Fund, and the National Center for Health Services Research. In 1970, the National Center for Alcohol Abuse and Alcoholism was established. A year later, the center moved to Hampton House, and in 1973, Sam Shapiro was recruited as director of the Health Services Research and Development Center. The 70s comprised of the passage of several key health acts. It also included the enrollment of the first class in the Johns Hopkins School of Health Services. And in 1976, the center moved to the 6th floor of Hampton House, where it's located today. Here we have a wonderful photo of our genius scientists, Pearl German, Laura Morlock, Sam Shapiro, and Don Steinwachs, plotting how to take over the world. Examining how to improve the quality of health services for populations across the U.S. There were several projects on primary care and quality of care, including work on the coordination of medical care, examining episodic health care, quality assurance in the Columbia Medical Plan, and a survey of quality assurance mechanisms in HMOs and prepaid group practices. Work continued on information systems design and health manpower, with projects on the development of outpatient encounter-based management information systems at the Columbia Medical Plan and East Baltimore Medical Plan, and also work on the Johns Hopkins Ambulatory Care Coding System. Additional projects include roles and productivity of non-physician practitioners and examining the accuracy of national medical specialty practice estimates. There were also several projects on financing, examining organizational factors associated with quality and cost in acute care hospitals, and looking at hospital reimbursement in Maryland as well. In 1979, the center received an epidemiological catchment area grant from the National Institute of Mental Health to work with the Departments of Mental Health and Psychiatry. The center also conducted research on the reliability of the abbreviated injury score and injury severity score. Fun fact, Ellen McKenzie is now Dean of the Bloomberg School of Public Health. It seems there may be a possible association between Cheshire membership and becoming a dean. However, causation is yet to be determined. In 1982, Don Steinwachs became director of the center, and in that same year, the center joined the Department of Health Services Administration, now known as the Department of Health Policy and Management. A year later, HIV was discovered. Please note that Don's facial reaction in this photo has nothing to do with the discovery of HIV. In the late 80s, COBRA expanded employee health insurance coverage, and the National Center for Health Services Research officially became the Agency for Healthcare Policy and Research. In 1986, Marilyn Bergner joined the center and brought the sickness impact profile to Johns Hopkins. 1987 marked the receipt of the first of 4 grants to facilitate the Center for Research on Services for Severe Mental Illness. The SMI Center is an affiliate of our center. In the 1980s, HSRDC affiliates conducted work on mental health financing and information systems, examining insurance benefit design, effects on care for people with severe mental illness, prospective payment for psychiatric inpatient care, and uses of healthcare administrative data to assess patterns of multimorbidity. We continued work on primary care and health status with projects on primary care in the U.S., drug side effects in elderly primary care patients, detection of depression in primary care settings, child health status measurement, and functional health assessment. All right, we've made it to the 1990s with the unveiling of the ambulatory care groups, later known as the adjusted clinical care groups, and Don Steinwachs becoming chair of the Department of Health Policy and Management, Jonathan Weiner being named Deputy Director of the Health Services Research and Development Center, and the enactment of the Health Insurance Portability and Accountability Act.
We once got a relatively small grant, I and my late colleague Barbara Starfield, to study patterns of disease and morbidity in enrolled populations in HMOs. An interesting story is that our Health Services Research Center here at Johns Hopkins was formed at the same time that 2 health maintenance organizations, HMOs, in the region worked, one for inner city residents, one for suburban residents. And we actually ran the computer systems for those HMOs. And we developed a tool now called Johns Hopkins ACGs that are very widely used in about 18 countries, about 80 million people, to better understand patterns of disease. And it's uniquely a health services research undertaking. We look at populations, we look at clinical patterns, we look at epidemiology, we look at costs. You know, a clinician or an epidemiologist or an economist would not have come up with it in the same way. And I'm really gratified that today it's now in use in many countries, about 15 or 16. It's in use in about 20 Medicaid programs. And every day it makes healthcare a little bit more effective, a little bit more efficient, and a little more equitable. And that's why I got in this business. So we at Johns Hopkins, one of the first programs in the world actually to train interdisciplinary health services researchers, Kerr White, who was a visionary, came and brought a lot of people, clinicians, sociologists, economists. At first it was one of each to form what, to the best of my knowledge, was the first or second program training doctoral level health services researchers. I, in fact, was at the end of the first cohort and then joined the faculty right after that.
In the late 90s, the Agency for Healthcare Policy and Research, now known as the Agency for Healthcare Research and Quality, initiated patient outcomes research teams. Roger C. Lipitz then created the Center for Integrated Healthcare with Chad Bolt as director, and in 1999, the Institute of Medicine issued their landmark publication, To Err is Human. In the 1990s, the center conducted innovative research on primary care, managed care organizations, outcomes management, home hospitals, medical errors, and severely ill hospitalized adults. The center also housed projects on schizophrenia, residential stability in women and children, caregiving and independence in older populations, the child health and illness profile, outcomes and quality of life assessment, and limb-threatening injuries.
I really think of the 1990s as a sort of a real go-go period in health services research, and especially clinical health services research. It was a time when many more physician researchers joined up with their PhD colleagues to do health services research. And this was funded by, among others, AHRQ, then known as AHCPR, and was certainly supported and promoted by Academy Health. There were some discoveries or some realizations. One of them was that there were terrific variations in how care was practiced across the country, or even across a different one zip code to the next. John Wenberg was instrumental in getting some of that work off the ground. And I will say that he was supported by Alan Gittleson, who was a professor of statistics at biostatistics at Johns Hopkins. There was a discovery that large administrative databases, like Medicare data, which is really used for billing, actually represented huge populations of millions of people who had health insurance, and that this was a terrific resource. There was a little bit of a discovery, and certainly a surge of activity in the science of meta-analysis, a systematic review of the literature, and synthesis of that literature. There was a new appreciation of the importance of patient-reported outcomes, quality of life, symptoms, some people call it health-related quality of life, and that these things should be measured, and in fact could be measured in a way that in many cases was just as valid as the so-called hard data.
Center affiliates also conducted research on ambulatory care case mixes, risk management, and health insurance. The new millennium brought with it the Medicare Modernization Act, including Medicare Part D, and the signing of the Affordable Care Act.
Without health services research over 3 decades, we really wouldn't have been ready when the window of opportunity opened for movement on affordable health insurance, and we wouldn't have been able to take advantage of this opportunity, this commitment by President Obama to make sure that every American has health insurance coverage.
The Center's projects only increased from here on out, with novel work on guided care demonstrations, examining prescription drug use in persons with severe mental illness, and the first of its kind National Health and Aging Trend Study. The early 2000s also brought with it a wave of patient safety work and comparative effectiveness research. We finally made it to the present, marked by the establishment of PCORI, the Center for Population Health Information Technology, or CFIT, and the Armstrong Institute for Patient Safety and Quality. In 2011, Albert Wu became director of the Health Services Research and Development Center. And in 2019, Daniel Polsky, Bloomberg Distinguished Professor of Health Economics, also joined the Health Services Research and Development Center. In 2012, HSRDC was renamed the Center for Health Services and Outcomes Research, Cheshire. I'd like to call your attention to our informal mascot, the Cheshire Cat, at the top of the slide. That same year, the Evidence-Based Practice Center affiliated with Cheshire, with Eric Bass as director. In 2013, Karen Davis was named director of the Roger C. Lippett Center for Integrated Healthcare. And in 2018, Jennifer Wolf succeeded Karen Davis as director of the Lippett Center. The center continued research on financing Medicare and financing health services, health status, functional limitations, quality of life, mental health assessment, and community-based participatory research. Quality of care research and patient safety research and comparative effectiveness work and patient-centered outcomes research continue to gain momentum with multiple PCORI grants and other research projects as well. And let's not forget our students. The Johns Hopkins Academy Health Student Chapter is a formal representation of student commitment to health services research. Advised by Jill Marsteller, the chapter hosts multiple events committed to the scientific and professional development of students in health services research. Notable accomplishments include selection for plenary presentations and success in thesis competitions, poster competitions, and student research competitions. Health services research. Its research domains are individuals, families, organizations, institutions, communities, and populations. Thank you for listening.
So I'd like to give a very special acknowledgement to Ann Skinner, our historian extraordinaire, historian laureate, master historian, PhD in history, and all things history related. Also principal investigator of this entire project. She basically wrote a book with all of this information, and then I had the honor of parsing through the information and trying to put it in a manner that's coherent to you all. Thank you. Okay, go ahead to the next person.
Dean Morlock, would you join us at the podium?
I may need a little help here in finding this. I think it's down. Can I exit out?
It's in your USB.
Yeah.
Okay.
Okay, perfect.
Please.
2. Yeah, thanks. Thank you. Okay, thanks. Thank you, Albert, and huge thanks to Ann Skinner for all her work in putting together so much information that's been amazingly helpful. I'd also like to give a shout out to Karen Thomas, whose recent book on health and humanity covers the time period 1935 to 85, and the center is really an important part of that effort. Karen, yeah, you're here. Hi. There's Karen. So I'd like to do a couple of things in 20 minutes. I thought I would start out, I'm really going to focus on the 70s. And I thought I would start with who I think we could consider the founders of the center. I'd like to talk a little bit about the projects that we were doing. And I didn't realize there would be interviews with Don and Jonathan, and Karen. They were wonderful. So I'll fast over things that are duplicative. I was very much a bit player in these events. I started, and I think I was always a research associate in the center. So that's the perspective that you're going to hear. We really, getting through the 70s was not for the faint-hearted, and I was really interested that Karen's chapter on this is called Surviving the 70s. So I'm often asked to talk about staying alive in the 70s, and we had a few things that we found helpful. A lot of humor, especially gallows humor during that time period. And then I thought I'd say a few personal words, not so much about why I came to the center, but why I stayed. And so that's more or less the outline here. I want to start with Bob Hisle. He came to Hopkins in 1968. He was the Associate Dean of the School of Medicine. He was an administrator in the Johns Hopkins Hospital. I love this portrait of him. It's in the Hopkins Portrait Collection, and I think it's, I don't know, really kind of speaks to some of his qualities. He headed the Office of Healthcare Programs, which was mentioned in the slideshow. And they were mandated by the university trustees to engage effectively in the organization and evaluation of new programs for the delivery of health services. So this was the center's first home, and as Anne and the film explained, the focus was to be on primary care, system design, health manpower, and financing. Later, Bob Hisle became president and then trustee of the hospital and a university trustee as well. So part of this vision were, as Jonathan mentioned, were two kinds of HMOs, the Columbia Medical Plan and the East Baltimore Medical Plan. These were both new types of financing. They were prepaid health plans. There were new types of providers. They were called health associates and health assistants, and they were trained at the School of Health Services, which was developed in the early 70s, and was also located in Hampton House. There were new information systems. And what I really want to mention is development was just not part of the center's name. The center was deeply involved in really all facets of the development of the East Baltimore Medical Plan. I'm showing here the new building that the East Baltimore Medical Plan had. Back in the days when we were involved in studying it, it was located in the basement of a church, the one with the high spire on Asquith. And the church charged them $1 a year. So the financing was very favorable. But we, collective we, were also deeply invested in the Columbia Medical Plan, design of the electronic health records, the information systems. We had a unit out there for 3 years, and I worked for a year there in that unit. There was a very well-known article about the Columbia Medical Plan by Bob Hisle and Henry Seidel, published in the New England Journal. So it got quite a lot of visibility. And in 1971, President Nixon announced a plan which was modeled actually on the Columbia Medical Plan that would provide unlimited medical treatment for $51 a month. And that was the beginning, that thinking was the beginning then of the Health Maintenance Organization Act in 1973. So 1973, enter Sam Shapiro. And I'd like to say really a couple of words about Sam. He was recruited as director of the HSR&D Center. I know Don, I think Pearl, I don't know about Ann. Others were on the committee. Sheila, were you on the recruitment committee? But there were, they had a job to do, and boy did they do it. He had a bachelor's degree. He also had some graduate training, but never finished a graduate degree. His graduate work was in mathematics and statistics. I'm going to argue in a few minutes. In a way, he was the perfect person to be kind of an arbiter between PhDs and MDs and a whole bunch of people with degrees. But he had an amazing depth of knowledge and skill and just plain perseverance. He served as chief of the analysis branch at the National Office of Vital Statistics. For a couple of years, he worked on research design and actually developed questionnaires for the National Opinion Research Center. So he came with, he was not just a data wrangler, he also had a lot of skill and experience in data collection. In 1955, he became associate director and then later director of research at the Health Insurance Plan of Greater New York. While there, during the 1960s, he conducted really pioneering research, which demonstrated for the first time that mammograms can reduce women's mortality from breast cancer. At the time, mammography was little known, and its side effects were unknown, and there were very, very few prepaid health plans, like HIP, that could facilitate doing this kind of research. By the 1970s, mammography was commonly used to diagnose and treat breast cancer at an early stage. In 1975, Sam was inducted into the IOM. We kind of thought of this as a beachhead for health services research. I'm leaping ahead here for just a minute, but one of the things Jill asked us to do was talk about magic moments. So I wanted to talk for a minute about 1988, where Sam became the first non-physician to receive the Charles E. Kettering General Motors Cancer Research Foundation Prize. This was a really big deal, especially for a non-physician. They gave him the award at a hotel in Washington. I think maybe it was the Hilton. We all went wearing evening clothes. We were really, really poor. This is going to be a theme of this brief talk. And 17 of us spent the night in a hotel room after Sam was awarded the prize. Anne was there. And I was there. And
Photos, we need photos.
This was before iPhones, fortunately. So I'd like to talk about just a few more people I really consider founders. One is Barbara Starfield. She was a pediatrician and researcher whose work provided really, for the first time, a scientific basis for the importance of primary care as part of a comprehensive health system. A lot of her research addressed the science of how to deliver high quality, equitable, and affordable health care to a population. She was an early advocate. She didn't call it patient-centered care, but that's exactly what she was advocating. She was also a really powerful presence in the school and in the health system, and was really a fierce advocate for equity and equality racial equality, gender equality. She had a really powerful voice. She was also on the committee which Bob Hisle chaired that made the decision in the late 1960s that the Hopkins Hospital wasn't moving to the suburbs. So she had a really powerful advocacy role. And she also had a very large professional worldwide network. So she didn't just publish, although her works have been translated into many languages. She also was there at the meetings, making the arguments for the importance of primary care. Another founder, I think, was Pearl German, who helped define and build the field of gerontology. It was not called that during Pearl's time. She utilized her knowledge of behavioral sciences to study aging and how to design supportive services for the elderly. She also built really an important interdepartmental curriculum in this area within the school. You can think of her in some ways as the grandmother of the Lippitt Center. She helped create the APHA section on gerontological health, which in 1989 gave her a Lifetime Achievement Award. She was also our poet in residence, and she had a quote for every occasion. My favorite being how wonderfully the shadow of the gallows concentrates the mind. She would put this quote up on her blackboard when we were working on proposals that like were due in 2 days. Don Steinwachs, engineer, operations researcher, and we all pitched in together on a big proposal to USAID one time, and they didn't require a PI, they required a chief of party. So forever after, that was the title that Don lived by. He joined the center in 1972, pre-SAM, as the research program director, later became assistant director, deputy director, he took over the center as director from 82 to 2011. He helped design information systems for the Columbia Medical Plan and the East Baltimore Medical Plan, but really he either led or was an important part of virtually every project we did during the 1970s. And he with Sam were also major, powerful forces in building health services research nationally. He was the first president of the Association of Health Services Research, for example, and did a lot of lobbying. Shouldn't call it lobbying, a lot of advocacy work on Capitol Hill. I'm going to talk for just a minute because we covered some of these in the slideshow, but I want to, I've organized the projects in a little bit different way, starting with those that were done at the Columbia Medical Plan, because what I think is really interesting and important is how grounded the early work was in the practical realities of delivering care. I should have mentioned that an important part of Hisle's, or let me say a practical aspect of Hisle's vision, was that you'd have the Columbia Medical Plan out in a new community, and at least you could call it a middle-class area, and that would help subsidize an HMO in the inner city of Baltimore. That was very much a part of the original idea. Unfortunately, one of the things that happened, well, let's put it this way. One of the things we learned actually in a large national study of HMOs a few years later is that size is everything. In fact, the two most powerful predictors of the success of HMOs during this period was size of the enrollment and investment strategies of the premium dollars. So this was a time when you could make investment income, and HMOs were insurance plans, so had investment income up front. The problem with Columbia Medical Plan is it didn't grow as it was projected to grow, and it was because the city of Columbia, the population estimates were about 10 years off. It took them about 10 years to catch up. So things didn't work the way they were envisioned, and financial struggles were predominant, really, during the 70s. So we did a lot of work out there. And one of the things I'd really like to mention is the Experimental Medical Care Review Organization. They were developing methods for quality assessment and assurance. They were one of 3 such programs in the country. They were far ahead of their time with respect to measuring patient-reported outcomes. Sadly, for about 10 years, there was no more funding to look at quality of care. But they were really far ahead of their time, and those of us looking at health manpower issues were able to use their data to look at outcomes for different practitioners delivering care. So one of the powerful aspects of a center conducting multiple projects is that you can sometimes get really amazing synergies, between and among those projects. You just heard Jonathan Weiner discussing what were originally called adjusted clinical groups. This was early work in the 1970s, done by Barbara Starfield, Sam Shapiro, Don Steinwachs on data from the Columbia Medical Plan, East Baltimore Medical Plan, and Maryland Medicaid. And subsequently, over literally decades, under the leadership of Jonathan Weiner and others, basically the rest is history. There were also other kinds of comparisons of primary care settings. There were studies done in the East Baltimore community, important early studies. And then as the 1970s wore on, there were national studies, a large study of HMOs, evaluation of regionalized networks for high-risk pregnancy by Sam and Marie McCormick, who later went to Harvard. There were medical specialty practice estimates. And then toward the end of the 1970s, there were new directions and collaborations. Award of the Epidemiological Catchment Area Program grant. Enter Ellen McKenzie with work on trauma and important measures of injury severity. So that is just a quick overview of the projects. What I'd like to do for a minute is talk about what were the forces that really held us together during this time period. And I'd like to say a few words about Sam, the center builder. So he arrived, world-renowned really, for his research. He was an intellectual giant, but what he also was is a team builder. And he had several skills that really impressed me and that I learned a lot from. One was a habit he had of deeply listening. When you went in to Sam with a problem, and it was typically a problem you were having with a project officer, we had 3 kinds of bad problems. There was the project officer problem. There was the journal editor problem. There were always, I would say, political skirmishes going on, especially in the health system and the hospital, that somehow we were always getting embroiled in. So you would come in and you would start talking to Sam. And Sam would look at you, and then he'd kind of sit back in his chair and his head would start going down. He'd close his eyes and his head would go down. And the worse the problem, the more deeply he was trying to understand it. I mean, sometimes his head would go on his desk. The first time I saw this, I was terrified. You know, oh no, I put him into a stroke. But he was focused. He was focusing on your problem. And his head would stay down, and then he'd think of a solution, and his head would come up. And you knew he really, really heard you. He had another habit. He had your back. And he not only had your back, he had everybody's back. And you knew it. And so what do I mean by that? Well, we had these meetings. We had, I bet, hundreds of these meetings because we were always submitting hundreds of proposals. And you really wanted to be part of a proposal. You did not want to be cut out of a proposal. But you couldn't always be there. So if you weren't there, Sam was there. And Sam would say, well, you know, if Sheila were here, this is what Sheila would want. Or if David Levine or David Salkever or David Celentano, there were a lot of Davids, you know, if he were here, this is the part that he would want. So you knew. I mean, think about it. This is really how you build a team. Also, he was instrumental and task-oriented in the very best sense of the term. He didn't let personalities get in the way. And if you were letting something get in the way, he would just kind of gently redirect you back to the task at hand. Sam helped build a new field. We came to the center as data wranglers, operations researchers, pediatricians, social workers, economists, internists, sociologists, engineers, behavioral scientists. This was not seamless or painless. There were some really awkward to painful moments. I still remember we were at one of our endless meetings about whatever proposal was due the next week, and I remember Pearl, and so things could get a little snarky, as I think David Salkever will talk a little bit more about in a minute. And I remember Pearl saying to Richard Frank, why do you economists always have to have all of these fancy models and complicated methods? And Richard went back in his chair and he said, you know, Pearl, when you were coming up, you could get famous on a crosstab. Famous on a crosstab is almost the definition of founding an area, founding a field. But people coming after you don't always have those advantages. So we basically were given a center name, Health Services Research. And what we did over the 70s was really develop an understanding of what that meant. So, staying alive in the 70s. I've mentioned that times were tough. But in 1976, we moved to the 6th floor of Hampton House, which opened whole new possibilities for us. So Hampton House was a really interesting building. It was the nurses' dorm. The nurses moved out and we moved in. We were on the 1st floor and the ground floor at first. Every room, it honestly was magic. Every room was like a little mini executive suite. It had a sink and it had a closet. And those really came, those were great. We also had a badminton court in the basement. Top floor, 9th floor was a wide open space with a huge ice machine, and that's where we had parties. So it was a pretty magic place, really. In 1976, when we were really starting to really struggle, we moved to the 6th floor. And that's when we started the sixth floor jump club. So there were a couple of rules. First rule was just because you felt like it didn't mean that you could jump solo. What you had to do was yell, jump. And then what the jump club was committed to doing was to gathering at your office. And you got to tell your story. And it was typically a project officer, a journal editor, or somebody who was denying you access to data. And then the group talked it over, and then the group voted whether there would be a group jump. So I really do think that saved a lot of sorry events during the 1970s. We also had some other plans. We got tired of all those proposals, and we were constantly talking about how we could diversify and alternative sources of revenue. Pearl German had the idea of capitalizing on our location near the harbor. She thought we could have a floating bordello when times got really tough, and she would be, of course, the madam. But Don and I had other ideas. And we also wanted to be closer to the community. So Don had this great sixth floor office overlooking the swimming pool. And our thinking was, how about a water slide? From his office. The idea was we would charge, this is a quarter, we would charge a quarter a slide. The community would be so happy during the summer. And so we spent some spare moments thinking about the design of this slide. I envisioned a fun, complicated trip down. Don was an engineer in safety and more simplicity, but Don and I used to, every time this photo would surface, Don and I would say, what we're really doing here is talking about the perfect slope for our water slide. If I have another minute, I'm going to, is that my time? I'll be really quick. I'm going to say a few more words about my personal background, how I came to join the center and why I stayed. And as the slideshow showed, the 60s were a tumultuous time. I was at the time in college in Michigan, but I spent most of my time engaged in projects in the civil rights movement. And one of them was in Mississippi. I spent a lot of time going back and forth between Michigan and Mississippi, raising money in Michigan for a program we ran in the summer in northern Mississippi. Martin Luther King would come once a year and help us. We charged $1 for a ticket, and that was an important fundraiser for us. And, when you think of him or you see pictures of him, he's in large mass lectures and marches. He spent a lot of his time traveling around the country helping projects just like ours. I was in northern Mississippi the summer that so I was at Rust College, and we ran something like a college prep program for high school seniors who were going on to college. It was a time when there was something called the Council of Federated Organizations, which is a lot of civil rights groups that were joined together. And I was there literally the week that the COFO signs came down and the Student Nonviolent Coordinating Committee signs went up. And it was the time of Black Power, and it was the right time, but whites were simply not welcome. in the civil rights movement. And so what happened next is interesting. A lot of my friends, and I think there's some statistics to bear this out, a lot of folks went basically into the anti-war movement. Some went into the women's movement. A lot of us went into academia. And I was one of them who went into academia. I went into a graduate program in sociology. And my question was really, what is it that so we were all traumatized, frankly. What is it that makes social change possible? What gives you the right to want to change something? These were the questions that I was really wrestling with. I ended up getting a degree in sociology, a PhD in sociology at Homewood. And I joined what became the Urban Studies Center, was recruited to a project by Tom Weiss, and decided, well, if I'm going to work on a health project, I'll just go downtown and work with other people who are doing similar work. I ended up staying, and in retrospect, I think it's really because of the core values that the people I've been talking about had. So they had a focus on improving the accessibility, quality, and value of health services. They were deeply interested in reducing health disparities. They were examining the social determinants of healthcare utilization and health decades before we had the term. And I think, most of all, they had a very deep commitment to social justice. And I think that has powered the center really all along. All centers involved. Yeah. Thanks.
I wasn't anticipating emceeing, but that was fantastic. Thank you so much for the very personal reflections. So we now have a cavalcade of prominent former affiliates, members of the center, and we're going to be kicked off here by Sheila West.
Thank you, and we were specifically asked not to do slides, so this is going to be a very quick overview of a little bit of what Laura was talking, but perhaps in more depth about that early adolescent period of the center. And I probably seem a little bit odd to you as a speaker about the center since I have a near non-existent career in health services research. Indeed, I was both pleased and a little bit surprised to be asked to speak about the center. But I think it's because I can bear witness to kind of that early adolescent phase of the center, and it reflects, I think, a very chaotic period of determining what the center was going to be, and at the same time what I was going to be. So when I thought about this talk, I thought about the title or the theme of it being transitions. It was a transition for the city, it was a transition for the university, it was a transition time for the center and for me personally as well. So as you heard, the 60s, the early 70s, Baltimore City itself was in transition. It was recovering from a set of devastating riots that left burned out homes and townhouses and empty lots, notably one behind Mamma Mia's, which became the People's Parking Lot long before it became homes yet again. The university was moving towards community engagement and thinking about alternative ways of delivering health care. And out of this crucible was born the Health Services Research Center. It was led by its first director, the charismatic, if slightly unfocused, Malcolm Peterson. As near as can be determined, his approach to building the center at the time was to recruit young, bright, energetic people with new ideas and to completely disregard their background or any research training they may have had at the time. And about the same time, I graduated from the University of California in San Francisco. As Laura, also I have a story imagining myself as one does in the 20s as a firebrand for change. And I was particularly interested in the feminist movement, but also in kind of new ways to use existing health manpower. And the use of alternative health manpower based on competency rather than a diploma was Malcolm's passion. And so presumably impressed by my ideas in that area, certainly was not based on my research skill at the time, he recruited me to the Health Services Research Center in Baltimore, and thus became probably the biggest transition of my life. I arrived, I mean, imagine this. So I arrived from ultra-liberal San Francisco to ultra-conservative Johns Hopkins University. I mean, people were walking around here in suits and ties, and I was used to T-shirts and tie-dye. So it was a real transition for me to figure out not only how to move socially within the center, but how to engage in a center that was itself figuring it out. Other center members at the time included 2 nurse practitioners who were providing health to East Baltimore projects, an architect and his brother, 2 guys working in health economics, Larry and Patrick, and they didn't stay for very long, and a social worker whose specialty was transactional analysis, and so that's how our faculty meetings were run. Fortunately, as everybody pointed out, Malcolm also recruited Dave Levine, the young graduate student Dawn Steinwachs, and Pearl German. When the nursing students vacated that first floor of Hampton House, the Health Services Center moved into its own space. And fortunately for me, I found mentors in Pearl, and we undertook some studies in physician prescribing habits. And Dr. Paul Stoley in the Department of Epidemiology, who was interested in research on physician prescribing habits. I'm going to digress for a minute because I have just a great story about Pearl, and I want to share that with you. So Pearl organized one of the first symposium on gerontology at the APHA. This was the first symposium she had organized, and she was actually quite nervous about it. And I can't remember now where the APHA was that year, but we were all sharing a room, Pearl and I and Ann and I don't know how many others. I shudder to think. And Pearl was quite nervous, and she had this phone call with a very prominent health services researcher, Ron Anderson, later that evening to talk to him about what he was going to present. And so she said, look, I've got to talk about this, this, and this. And I said, come on, Pearl, we're going down to dinner. Let's have some dinner. You got to relax. Well, Pearl had dinner and a certain amount of quantity of wine. And we went back up to the room. Pearl was feeling quite fine by that point. And the phone call came, and she talked to him. And at the end, she said, I did great, right? I said, Pearl, you talked to him perfectly, except the entire phone call, you called him Ann Ronderson. So, which I never, after that, speaking was pretty easy. Well, I suspect that all new centers have a rather painful adolescent period, and our center was no different. After acquiring a Robert Wood Johnson Foundation grant to establish the School of Health Services, Malcolm channeled all of his energy into that school and channeled most of us in the center into starting a training program for the health associates. Also based at Hampton House, the line between the School of Health Services and the Health Services Research Center became blurred. The development of curriculum, the training of new people, they became full-time jobs for some of us in the center. And this split led to a lot of chaos at that juncture in the identity of the Health Services Research Center and the identity of the School of Health Services. But that chaos quickly resolved when they appointed Sam Shapiro as the new director. The transition to Sam, who was solidly based in the field of health services research, made the direction of the center quite clear and established a sound research base to ensure it became the mature and valued enterprise it is today. As for me, I left to pursue a postdoc in epidemiology. I headed off into international waters, And honestly, as I look back, though, those early experiences were transformative for me in defining my career, what I needed to succeed, and my true research passion. I still look back fondly on those days. Those pictures were wonderful to see. Fortunately, they included none of me, which I'm grateful for. And I, from afar, have enjoyed watching the success of the center and its growth over my, 40 plus years of having been at Hopkins. So congratulations on the 50th to all of you. And I'm going to turn the next speaker over to, I think it's David, yes? To also reflect.
So this should be starting to sound a little familiar. I completed my doctorate with George Comstock in Washington County in December 1976, and in January I joined the School of Health Services in the Office of Manpower Studies. And so I was hired to do, by Malcolm, to do an evaluation of the Health Associates, Physician's Assistants, and Nurse Practitioners program. And I believe the school closed, and I think I was the last person on the payroll. And I did the final evaluation, which we turned in, I think at the very end of December 1977, and I was out of a job. That happens when a school closes. January 78, I joined the faculty of the Department of Behavioral Sciences, and a deal was brokered between what was then the Cancer Center, now the Sidney Kimmel Comprehensive Cancer Center, and the School of Public Health to develop a state plan and interventions in cancer control and prevention. And I was fingered to do it. And the person who brokered this deal was none other than Sam Shapiro. And so I began what I now refer to as my 5-year postdoc with Sam. And I very quickly learned, actually I didn't learn very quickly. It took me a while to realize that the head nodding was a time to zip your lips. Because I would try and jump in and he'd come back up and look at me. And then I realized, okay, shut up, David. And that's what I did. So we were tasked with developing cancer control plans for the counties in Maryland. And we did, of course, a bit of an experiment, and we matched counties and really did interventions in one and let usual care be the other. So it was Talbot and Wycomico and Carroll and Frederick counties. And we did a lot of work on that. But this was all part of the Cancer Center's 5-year plan. And I believe it was the 1980 renewal that I was late with my specific aims. And the person in the Cancer Center, sort of a master's level person, Donna Cox, said, at one point I was late, and she said, I'm going to have you fired if you don't get your specific aims in. And I thought, well, that's an interesting concept. Nobody else has ever been late before, but that was okay. Then Sam and I got a contract from the City Health Department to look at cancer mortality in Baltimore, and I can't believe I found it. This is the final report to the Baltimore City Health Department, May 2000, in which, you're going to love this, see if I can find it, hand-drawn. And, you know, Laura said Sam always had your back. He always had your back unless there were reporters involved. And so I presented this report in Turner Auditorium. It was full. And, you know, when I started working with Sam, I was 28 years old. I mean, he was a force to be reckoned with. And I quickly learned he was sort of my Yoda. And so I gave this talk, and I presented the data. And I came out of Turner. As you know, you go up the thing. When you go out, you go up So I walked out of the building, out of the main hall, and there were about, I don't remember how many TV cameras, but there was a phalanx of TV cameras and reporters, because this was showing which neighborhoods in Baltimore have high cancer rates, et cetera. And I guess Laura should tell the story. At the top of Turner Auditorium, Sam and Laura were watching this. And
I said to Sam, shouldn't you go down there and help him? And Sam said, oh no, he can handle it.
yeah, right. That was very interesting. My experience was I was not an insider. I was what now would be called affiliated, but I didn't have an office in the center. I met with Sam probably twice a week, always a little frightening. I've never seen a red pen used quite the way, you could not see any of the black type from my typing. But I learned how to write from Sam. And after that experience of working on this cancer control program, I wrote an R01 on basically why do we have an excess of cervical cancer in elderly black women in Maryland. And it's obviously it's a function of screening, but no one had ever really put the two pieces together. So what Sam sort of infused in me became my second R01. And I really always, thought about Sam as sort of foundational, along with George Comstock and Abe Lilienfeld, who really had incredible impacts on my career. And just as Ellen ended up being dean from the R&D Center, I became chair of EPI. So.
David Salkever.
Yes, indeed. I'll try to be brief and speak loud so that the grumbling in your stomach doesn't obscure what I have to say. I'm just going to make a couple of brief comments really about why I enjoyed so much working with the folks here in the center and doing research projects and to some degree some of the interesting perspectives that I learned that I did not arrive with when I joined the center, but had to come to appreciate sometimes the hard way. My official academic home at School of Public Health was in the Department of HBM, and I joined the faculty there in 1972 and stayed through 2005. And for almost all of those years, and this I guess is parroting a phrase that perhaps was one of Ann's slides or one of the earlier slides, that I really viewed the center as sort of my academic home away from home. It was in fact the main locus for most of my research collaborations and inspirations. It was an exciting place where colleagues' doors were almost always open. A place that had an opportunity for freewheeling, no-holds-barred exchange of ideas, of gossip, of jokes, suggestions for research strategies, strategies for communicating your research, and of course, strategies for getting money to fund your research. I'm going to talk about two brief themes that in reflecting back, I thought were especially important to me as I sort of flailed my way through the several decades that I was here at the center. First, I have to confess that I arrived here at the center as a newly minted PhD economist from an Arts and Sciences department. And basically what we learned about there was that the key elements of empirical research was to first find an interesting secondary data set, preferably one that was very well cleaned and edited, feed it into the computer and crank out your regression results. There wasn't, most of the emphasis was really on sort of conceptually how should I think about the data that I had and how should I put the model together given the data that I had, and not much thought was given to actually trying to figure out how to collect data that would speak to particular questions that were interesting. So I came over to the center and was suddenly confronted with all of these folks who could actually construct surveys, collect data targeted specifically to their research questions that they wanted to address, which was a pretty new concept for me. When I look back on it, virtually all the major projects that I was involved in, especially during that first decade at the center, involved original data collection rather than simply going out and grabbing some tapes that were generated by a government agency and cranking through them. Fortunately, there were lots of colleagues here, like Anne, like Pearl, Laura, Faye Malitz, Sam Shapiro, David Levine, and others who had lots of experience in doing this kind of stuff and constructing surveys and carrying out data collection efforts and supervising interviewers and all that kind of gritty stuff. These were all things that I knew absolutely nothing about, and I would like to think at least taught me some useful lessons. The early projects, and they've already been mentioned, I think, some of them included the East Baltimore Community Survey, which was a household survey of a large swath of neighborhoods around Hopkins Hospital, where we were focusing very specifically on ambulatory care and preventive care and doing our household interviews. There was a survey of public service employees in healthcare placements, which Laura and I had a lot of fun with, especially when it turned out that our results ran very counter to the predilections of the officials in the Reagan administration, who were ultimately on the funding side of the projects, and not at all pleased to hear what we had found. And I think someone had already mentioned some of the work we did at the Columbia Medical Plan on comparing physicians and nurse practitioners in terms of treating pediatric otitis media episodes. Indeed, the whole idea of an episode of care was something that I had never heard of before I wandered through the halls of the center and actually started thinking about that as a concept, which I had never heard of. Now, a little bit later on, there were, of course, more folks in the economics fraternity, or at least economics-oriented people who joined the center staff, like Agnes Rupp. Don was sort of, I guess, kind of half an economist. Richard Frank was interested, obviously, in a lot of economics work, and former student and colleague Allison Jones. And so with those folks, I did have a lot of opportunities to go back to my comfort zone of basically secondary data analysis. Though in a way, I think the earlier work was still key to some of my later projects that again involved folks at the center. A big project on rural hospitals with Laura and with Steve Mick over in HPM, and again involving Faye Malitz, and then of course Ellen's study on national study of outcomes for trauma care with a number of other colleagues in various departments that was relying very heavily on some original data collection efforts. I think it's interesting, at least to me, to reflect upon that approach to data research and how much it contrasts with the present day, when we hear all these thoughts about and suggestions about big data and how the research balance is again becoming much more heavily weighted toward going out and just grabbing all the data that you can find that other people have collected and seeing whether you can somehow wring anything sensible out of them. In contrast, when the work that we did at the center, where we were involved in developing our own data to be used for our own projects, really involved lots of forethought, informed decisions, and thinking about the data items that were actually worth collecting, the ways in which they were used, and also what they actually meant and how they related to the precise wording of our questionnaires. I guess I'm saying this is a bit of a curmudgeon, but my sense is that it's clearly not the case with big data studies that are coming up today. And I confess to harboring some suspicion that this transition from a somewhat more cautious and deliberative approach to data may have its costs down the road, but that may be something that is at least tangentially relevant to the second part of the symposium today. So the whole issue of sort of how to deal with data and thinking about data, I think, was very important and had lots of lessons for me that I learned from the folks at the center. The other aspect that I think was important was really a much more personal, kind of touchy-feely aspect of the work here. Really the spirit with which we all approached the research enterprise. Now you've already heard that the research productivity at the center in those early years, and of course it's continued, was widely recognized in global health policy and health service research communities. But I think what might have been less widely appreciated was that one of the really important ingredients in this success, in my view, was the humor, humility, and as Laura's already previewed, even occasional but good-natured snarkiness that characterized our daily interactions. I mentioned already the importance of original data collection just a few minutes ago. Even that had its humorous side. And of course, Pearl German plays a prominent role in that story as well. At one of our center staff meetings, we took a break to consume a very nice catered lunch that was provided. When we returned to the meeting room, we were greeted with a non-confidential single-question health survey from Pearl. She wrote on the blackboard in the room and asked us to signify by a show of hands our answers to the following question. How many of you are now experiencing acid reflux? Of course, this had absolutely nothing to do with the topic of our meeting. Other less data-oriented but nonetheless memorable occasions included the appearance of an exotic dancer at one of our center staff functions. I think Jonathan will certainly appreciate this one. The surreptitious awarding by the more junior staff at our retreats of a prize named after a senior faculty member. This award went to the meeting attendee who executed the most blatant redirection of our group discussion to the individual prize winner's own accomplishments and interests. Of course, there was no public announcement of who the award was given to. I also remember some extensive private chuckles we had about one staff member who was always first in line to collect all the leftovers from our luncheon meetings, and Skinner reminded me that this collection process even included post-luncheon raids on the 6th floor refrigerator where some of the remaining leftovers were stored. Parenthetically, let me add that in defense of this person, I do recall that in those days, salaries for assistant professors were pretty meager. One other instance that I'm aware of, and again, this one relates to both Pearl and Sam, and David Levine reminded me of this, but I think it perfectly captures the combination of humor and humiliation and snarkiness that livened up our daily interactions. Pearl had asked Sam one day about advice for sending one of her manuscripts to a particular journal. Sam quickly read the manuscript and told her that she should definitely not send the paper to that journal because they would not accept it. Eschewing Sam's advice, Pearl went ahead and sent in the paper to that journal anyway. Then, when she heard it was accepted, she immediately told Sam that he'd been wrong. Sam said, this is a rough quotation, "Well, I guess nobody's perfect." Pearl didn't ask to whom that comment applied. Of course, given the pressures to publish and get funding, a certain amount of the humor that I recall and others here have mentioned, and Laura's mentioned it specifically, was needed and was generously supplied by colleagues. And Laura already mentioned the Jump Club. By the way, I'm not sure if people were entirely aware of what the Jump Club was referring to in terms of a jump, was jumping out the 6th floor window and landing on the sidewalk below in one shape or another. There were also, of course, lots and lots of jokes, good news, bad news jokes that were told once we got our dismal study section priority scores after the first submission of R01s. Now, in looking back, I don't think I was as aware at the time, but in reflecting, I do realize that the collegial atmosphere of the center not only made the work more enjoyable, but also made it a lot easier to share ideas, to encourage, to criticize where needed. And I think that really did have a positive effect on productivity and quality. Albert has mentioned the concern about maintaining the personality of the center as it grows and grows, and I think this is one important aspect of that success for the center that hopefully can be maintained. So reflecting on all of our common efforts does bring to me a sense of satisfaction and a smile, and I do hope that in the future those of you who are working in the center now, when you look back, will feel the same way.
We have Kevin Frick, who's eloped to the business school, but has deigned to come back.
Thank you. So I am the only thing that stands between us and lunch. So I am going to try to make my comments interesting and not too long. So I joined the center in 1996. Thinking about where I was before that, I had just finished my studies in my PhD program at the University of Michigan. I was in their School of Public Health and Department of Economics. So my setup was, unlike David's economics training, I'd actually worked with a health economist in the School of Public Health who did primary data collection. I had worked with a social epidemiologist on an interdepartmental, interdisciplinary type of project. And then I wrote my entire dissertation on theory, which is a great setup for coming to a department where almost everything runs on empirical grants. So that's how I entered into the Health Services Research and Development Center when I joined the faculty. And thankfully, I got put right across the hallway from Jonathan Weiner. That set me up to get involved in data-driven projects immediately, which is a good way to start one's career. Also in 1996, the U.S. Panel on Cost Effectiveness in Health and Medicine released its book, which I went and attended their opening talk about the book. And that set me up for more than enough opportunities once the center at the time was, had grown bigger. There were more and more different things going on. And what the center provided for me, and has provided since then, is a set of opportunities to diversify within the center and diversify around the rest of the school and the rest of the East Baltimore campus with ideas that start from the center and ultimately come back to the center. So earlier this year I heard David speak at another ceremony, and he described himself as a bit ADD when it comes to his career and his academic pursuits. And I thought to myself, after years of struggling to describe my own career, that was a perfect description for my career as well. Because for years when I was a junior faculty member, colleagues inside the center and elsewhere in the department kept saying to me, Kevin, can you focus a little more? Can you find a way to describe to me this year in fewer words than it took you last year, what you're going to be known for when we put you up for promotion? And I hear that's advice that the faculty member who gave me that piece of advice still gives junior faculty. And each year I said, no, I don't think so, not my style. And for better or for worse, that's what I did. So what the center provided for me earlier in the very first presentation, talking about the Lippitt Center, talking about the Primary Care Resource Center. Those are two of the places that I reached out to. When I first came to the center, and again, cost effectiveness panel had its book, and Don Steinwachs got a call from Kay Dickerson, who at the time was at the University of Maryland and has since been in our Center for Clinical Trials, although I didn't realize she was emeritus now until I looked her up this morning. But she was coordinating a multi-center clinical trial on surgical treatment alternatives for dysfunctional uterine bleeding. They wanted a cost-effectiveness component. And once at the time, back in 1996, I got known as the person most interested in doing cost-effectiveness studies, and that opened all kinds of doors. It opened doors for Don to introduce me to Sheila, and we worked on a project looking at nursing homes and screening for vision problems in nursing homes and trying to facilitate access to care. It opened the door to the Center for Clinical Trials here even before Kay had circled around and come back to Johns Hopkins. Worked with Albert on the study for ocular complications of AIDS, worked on a study for uveitis treatment, always with a cost effectiveness component. People in the department had, again, you had Chad Boult and guided care under the Lippitt Center. Also ties from talking with Pearl, working with Judy Casper on a few projects, and then that combination also working on Hospital at Home with Don and Linda and John Burton and Bruce Leff and a few others. That set of things in the aging space then got me tied to the Center on Aging and Health, and that opened up the opportunity to collaborate with Linda Freed and George Reebok and multiple others on the Experience Corps project. Within the center, also plenty of opportunities to collaborate. I've mentioned many people already who are within the center, and certainly in the time that I was there, Claire was trained in the department, and then she and I think it started out with some leftover resources from one study, and we started working on cancer survivorship using SEER Medicare data, which then built to some seed money from the school, which then built to an R01. And so that was a nice opportunity as well. And so again, I entered the center, I think I'm the first one who's spoken today who was born after the center started, although only by a little, because I will turn 50 in January. But joining the center when it had already been around for more than a quarter of a century is a much different place in the center's history. And rather than having the center's projects, which other speakers this morning have talked about, it was more of a loosely affiliated bunch of people at the time, not with one common agenda item in terms of doing excellent, high-quality health services research to help change what's going on in the field. That joined everyone together and still joins everyone together in the center, although the research projects and the areas of interest had become quite diversified by that time. So in the 16 and a half years that I was much more formally affiliated with the center, it gave me this opportunity to build this network. And it's not even really a hub and spoke. It's more like a crazy-shaped web with lots of interconnections, not just from me to the people I was collaborating with, but even among the people I was collaborating with who were collaborating with each other in totally different projects that I had nothing to do with. But it's really the sort of kid in the candy store who has ADD opportunity to build and establish and think about where I'm going and where the field was going. And what's interesting is in the 6.5 years since then, thinking about how foundational those experiences were. Because in a business school, what do I teach my students? I teach students about the importance of networking. Well, that's what I built in the 16.5 years that I was here. Mentioned the focus on excellence in research that not only is going to be published, and hopefully not just sit in a journal and get read by 5 people, but actually change practice. In business schools, we're just as interested in changing practice, so bringing that with me is also quite important. And finally, you can never quite leave it all behind. I am still mentoring someone from my own undergraduate institution, who I began mentoring while I still was with the center. And despite what she originally thought she was going to do, she got pulled into health services research eventually as well. She now works for Academy Health. And just 1.5 years ago, she said, we have this paradigm project where we're thinking about the future of health services research. Would you want to be involved? And I said, well, I still read the literature, still trying to stay actively involved. And so she brought me back because she thought that with the combination of all that I had done for the time that I was here, and with the continuing focus on the translational aspects of research, wanting to have an impact, as we phrase it over in the business school, thanks to our accrediting body, wanting to engage, innovate, and have impact. All of those are so quintessential to what the Center for the Health Services Research and Development Center, and now Cheshire, has been about for its entire career. And so I think it's just really fascinating to think about what was available 23 years ago when I began, what I was able to make of it through the advice, but if you can make it on your own and diversify as much as you want to and run with your scattered approach to your career, which I don't necessarily recommend, but it did work for me, and just taking advantage of every opportunity that was provided, it's something that I don't think I could replicate anywhere else. It's something that I value immensely, and something that I hope that spirit of maybe tame it a little bit, but do the innovation, take advantage of the multiple opportunities, And the sky is the limit if you can build that network and successfully sustain your work. Thank you.
Wow, guys, that was really amazing. I mean, I learned so much. There was so much I didn't know there. I thought that was really wonderful. And so much that was really groundbreaking and so important, too. So everybody keep that in mind as we adjourn for lunch. We're going to be doing an activity during lunch, okay? So we're going to spend about 45 minutes. We are going to try to reconvene back in this room at 2:30, so everybody hang on to that number as well. But what we're going to do at lunch, take a look down. Everybody look down. You've got a name tag on. Your name tag has a dot. Your dot tells you what color table you're sitting at for lunch, okay? So if you are orange, go to the orange table. Find the table that has a little table tent that has an orange dot on it, or whatever color you have, okay? So that's how you're going to separate into groups so that you can meet some new people instead of always sitting with the same people that you already know. And then you'll see on the table tent there is a question, and that's your topic of starter conversation with these folks that you don't know, okay? So great. Thanks, everybody. Lunchtime.
I don't know if people in the lobby can hear this, but come on back in. Incidentally, if you haven't seen, there is Cheshire Swag, that is to say coffee mugs with a custom designed logo for the 50th anniversary, and also a sun catcher, I'm told is what they're called, which can stick on your window and remind you every day about all of the light that health services research and Cheshire has shined upon you. So that's all outside on a table. Pick up your swag on the way out. I'm about to introduce Jill Marsteller, who's going to introduce the next part of the program. Oh, all right.
Just click skip. Escape. Okay, great. So for the next part of our day, we're going to be hearing for, now that we've talked about the past, it's time for us to start thinking about the future. Yay! All right. And so we're very lucky today to have an actual, real live futurist to talk to us about the future. And I'm trying to find your slide set. Which one is yours? Since you get to choose all of them. Oh, how innovative. Ooh, everyone's ooh. So come on up, welcome if you will, please, Jonathan Peck from the Institute for Alternative Futures. Yay.
Thank you, Jill. Thank you all. So how wonderful to journey back over 5 decades and see how Cheshire developed, the projects, the people, and especially the core values, that deep commitment to social justice, so that you know this legacy is available to you. The past, however, is an important, though inadequate, guide for shaping the next 50 years for Cheshire, for thinking about the research opportunities that will be available. So for the next half hour, what I'll be doing is inviting you to think about futures. And I actually went to a graduate school in future studies, and the professor there is named Jim Dater. And Dater famously said, any useful statement about the future should sound ridiculous at first. So I imagine when you woke up this morning and you thought, I'm going to go to this symposium this afternoon and say something ridiculous. And you think, okay, here you are among some amazingly smart and educated people, and you're going to say something ridiculous? And yet, don't you agree that if you think out 50 years, there's going to be some amazing surprises, things you're just not expecting? And only if you give yourself permission to think beyond your expectations, to be able to say something ridiculous that at first people think, no way, and then over time they say, yeah, no, maybe there is. And then they start to see evidence that, yes, it will. Now, there's real value in that. And so for each of you, particularly if you're younger and you're starting to think about what's my career going to be, there's some well-trodden paths, the expectable. And there are also some people who go off the path. And people like Sam Shapiro, who, you know, didn't even get a PhD or an advanced degree and yet became such a pioneer in the methods. And so the ideal here for you is to let yourself think about something ridiculous. But I know that's hard. And, you know, you haven't been spending 38 years as I have going out and saying ridiculous things in front of smart people. So what I'm going to propose to do is I'm going to give you 5 ridiculous statements. These are forecasts. And your job is after each one to imagine that this actually happens. And then to say, if this happened, what would it provide as an opportunity for Cheshire research projects that would make those projects likely become really important in the decades ahead. So you want to honor the past, this legacy you've been handed, and yet you want to go beyond the past to say, how can we transcend that to be even more important 50 years from now? And I'm convinced that these ridiculous forecasts I'm going to give you can help. So we're going to try the first one, and here's what we'll do. I'm going to give it to you, give you a minute to think about it. If you have something to write on, computer, whatever, or if you just want to think it through, then say, if this were to occur, this is what I think would be a really great research opportunity for Cheshire. And then I'm going to give you that minute, and then I'm going to ask you to turn to somebody next to you or near you and share the idea. Here's where that deep listening skill comes in that you heard about. If you really listen carefully to what's underneath the idea, to the understanding of what this opportunity is, to the assumption that something big is changing in the world that's going to open up a way for Cheshire to actually do research that will be more important over the next 50 years than anything that you might expect right now. So that's the goal here. And we're going to go through those 5 areas, and that's going to be hopefully helpful for you thinking about your opportunities, especially if you're younger and you're looking at a career that may be very important in this world, but also for all of us to be able to say, you know, where is the legacy, where's the contribution we can make? So we're going to start with policies. Here's the statement, the forecast. This is ridiculous. Local policies change healthcare systems in the decades from 2020 to 2070. And those that prove most effective become state policies. The federal government plays far less of a dominant role than communities and states in 2070. So this is going out to from 2020 to 2070. So it's a 50-year time frame. You're thinking forward. And it's the local policies that are shaping health and healthcare in 2070. So forget about the federal government. That in the 2020s became so problematic that the health policies didn't do much. States learn from local.
Sounds unbelievable. That doesn't seem like it's
ridiculous, huh? Yeah, ridiculous that our federal government couldn't work. Okay, you got it? Okay. Think about what research opportunities will open up when it's local policies that are reshaping health care and health. Okay, share your ideas. Going to give you a few minutes for that. Okay, I'm from New York, so I'm quite comfortable interrupting. And I'm going to just share one answer as sort of a modeling, and then I'm going to invite some other answers. We're going to see sort of what, if there's anything that you're converging on as a research area. Ann and I were talking beforehand and going back through memory lane a little bit, and so I was into the health policy arena as a futurist. I came to Washington in '82, and you know, we were looking at the slide that was talking about Nixon's and the HMO, and really what that came about was because in the 60s, when Medicare and Medicaid were first put in, I remember there was, anybody else remember HCFA, Healthcare Finance Administration? And so the HCFA had done a projection of Medicare costs from 68 into the 80s. And it kind of looked like that. And then I once saw a graph of the actual expenditures, and it went like that. And it was so dramatically off. And so beginning in the 70s, there was real alarm at the federal government. Said we have to have cost containment policies. So the HMOs, and you know, we've gone through decades of cost containment, and it's never worked. Costs have kept going up, and so we're at, let's say, 17 plus percent, probably headed to 20% of GDP that's going into healthcare. And the forecast I've got, and this is in Health and Healthcare 2032 scenarios, is actually local policies are how we finally get a handle on over expenditure on medical costs, while health doesn't improve. And so it's the local figuring out of how do we constrain the medical expenditures, particularly at the end of life. You know, frankly, as you know, I'm headed towards 75 and 80. Spending a lot of money on me is a mistake. It would be much better to spend it on a little child to set them off for a greater life of fulfilling their potential than on me. But there's no way federal government figures this out, and state and the politicians aren't going to make it happen except local. And so it's actually local councils that figure out how do we really get our local policy so we're not allowing expenditure, medical inflation to go running rampant where the value proposition to the health of our community is low. And it's the states that then pick up those ideas that are working in different communities and spread those, and that's how the policy occurs. So that's my forecast. That does say that the research opportunity, I would think, that would emerge for Cheshire on that would be to really find those local leaders who are making a difference, to look at the data sets that demonstrate that this is a very high value proposition, and that would work to then seed the data from the local to the state level. So who else has something that they'd like to put forward and say, here's I think an interesting research project that Cheshire might do given that forecast? Yes?
So in a way, you're proposing a different evolutionary pathway.
Well said.
Just using Darwinian evolution,
Mm-hmm.
different environments can lead to very different sort of speciation, so to speak.
Yeah.
So some research questions would be, what organizational structural changes occur? To what extent is there divergence along those lines over a period of time?
Mm-hmm.
What are actually the health outcomes implications of all of this? And then what are some, if it were possible to do, opportunities for the economists of the world to do some modeling to see which are the determinants or the predictors locally that might have helped to explain what some of this difference in the observed is relative to what you might have projected absent this evolutionary change.
Nice. Yeah. So in evolutionary terms, what may work in one ecological niche may be due to local conditions. Right. If the research showed that, then other communities that had those local conditions would probably be able to learn from that most effectively. Is that?
Yes.
Yeah.
If I just might just say one last little thing here. You may be familiar with the phrase, but Louis de Brandeis, the Supreme Court Justice, referred to this as the laboratories of democracy.
Yeah.
Now, I think it's probably a little bit different nowadays, given the scenario that you're just describing, but that has been a strand of thought over in some areas over the years, to see how states adapt to different circumstances and how that evolves, and what works and what doesn't work.
Yep, makes sense. Anybody else come up with anything close to that as a research area in a future where it's really local policies that are shaping what makes a difference? No? Anybody have something completely different? Jill?
I mean, we were really worried about the amount of disparity that would be created by that. And we initially, actually I opened by saying, well, my sample size on organizations research would increase dramatically because I'd be doing county level research and there's tons of counties. And so I was happy about that. And then we started talking and said, yeah, but you know what's going to happen is there'll be that, what they call the race to the bottom, to provide as little as possible. Or another way to think of it is that counties or areas that are already under-resourced are not going to be able to provide much in terms of healthcare support. and so things will get just worse there. And then in counties where they can provide lots to people who maybe don't need as much, then they're going to have a great life. So that was what we talked about, and as a research project, just using the natural variation that was mentioned before, from a statistical perspective, it gives you something to be able to work with in terms of predicting outcomes and figuring out whether some of the social circumstances are actually influential, as well as government policy.
Great.
We raised it as everyone in the red states dies.
Well, we do kind of have a natural experiment on that. I thought it was fascinating. Have you seen that there's actually those states that adopted the Medicaid, they have more diagnosed diabetes than the states that didn't? And the key there is diagnosed, right? So what are the outcomes going to be 10 years from now? So that's it. Yeah.
I think what you're saying is quite possibly true, but to kind of flip it around, it could be that the counties and communities with less resources have to do more with less and then end up being a model for more effective programs that we could learn from.
Mm-hmm. That makes sense. I mean, there's an argument, if you look at the studies internationally, you see the shorter lives, poorer health, that by spending more on medical care, you're actually taking from social service spending, and those counties that say maybe by spending less in medical care, people do better, and that would be possibly an outcome. Good point. Okay, yeah, one more, and then we're going to move to another ridiculous
There was
thing.
definitely discussion about things at the county level, but rather than the particular focus that Jill had talked about, thinking about if things are changing at the county level, does that make dissemination of the ideas quicker?
That's great.
And in terms of thought leadership, could thought leadership at a more local level get ideas and get experimentation and innovation and fail and innovation try again much more quickly?
That's a great point, yeah, and that makes sense to me, certainly. So if we're talking about the laboratory of democracy, the question is, what's the fastest rate of learning we're going to see? And is it with the more top-down structure of federal, state, local versus this that is bubbling up from down below? Great. Okay, you ready for another ridiculous one? This is on the topic issues problems. Infectious diseases spread globally to become major killers and maimers by 2030. The weakness of WHO and the CDC makes early identification and tracking of pathogens and memes a key function for networks of public health officials, corporate partners, and community leaders. Do you want me to read that again? Infectious diseases spread globally to become major killers and maimers by 2030. The weaknesses of WHO and the CDC makes early identification and tracking of pathogens and memes a key function for networks of public health officials, corporate partners, and community leaders.
It means, and the consequence is everyone in red states die.
Well, I think, how is it different from today? The scale of, so if you think of the scale today of the human population, so we're 7 to 8 billion, right? And you think of the potential for a pathogen to very rapidly infect this global population. If you took, like, for example, the Spanish flu back in 1918-19, there was maybe 2 billion people back then, and it killed maybe 50 million. In this, by 2030, where we'll be 8 to 9 billion people, the rapidity and the scale of death is going to be very different from today. So the counter ability to identify and slow epidemics and reverse them is going to have to evolve very rapidly. And so we're saying it's not going to be through WHO and CDC, which would be the main players today. This in this forecast is saying the early identification, tracking of pathogens and memes. These are the social things that people are expressing that give you cues about the spread and the potential for prevention of spread. That becomes a key function of networks. Networks of public health officials along with business leaders and community leaders. Okay, think about that for a minute and then share your ideas about what research agenda that would suggest for Cheshire thinking forward. Okay, we're going to have to pick up the pace. I'll take two ideas and then we're moving on to the next forecast. Who's got one that they'd like to put into the room? New ideas for research. Yeah, Jill?
Well, so we thought about the idea of using social media as a surveillance mechanism but developing like icons or something where people could sort of show just an easy, like, I'm sick, and it could be an icon or something like that, or I'm happy, the same way we say we're feeling whatever on Facebook, we say I'm feeling blah, blah, blah today. And then, using massive computing to sort of scrape all that data and figure out what's happening. And Vadim thinks everybody's pretty much dead, so he wants to have an icon that says "I'm still alive." That'll be one of the icons, and then they'll count that and know who's still on the planet.
Yeah, that makes sense. In fact, based on Google searches, people were able to track early epidemics on some of the viral infections much faster than any case report or doctor reports. They would just look at who was Googling for the symptoms, and that would show the spread more accurately. Okay, good. Anybody else have one? Yeah, great.
So we were talking about wrist wearables or wearables that can now detect temperature.
Yep.
Actually being sort of gateways of where people have access to things, including work and other places. And there are lots of sort of ethical and other questions that you could ask.
Yeah, great example. Yeah, I think they were toying with that in Singapore without the ethical questions. Okay, yes?
One thing that we briefly mentioned, I think with a concern of there being corporate partners involved in this, there'd be a lot of ethical and policy considerations of who owns that data and what are the barriers for health systems and departments of health to access that in a meaningful way.
Yep, makes sense. Kind of like there are today with Facebook, right? Yeah. Okay, you ready for the next one? Okay, so, hey Siri, where is the best help for me with diabetes? AI apps provide the best access to diagnostics, prognostics, and quality care options in 2070. And these apps are more emotionally attuned to patients than human providers, and they know more. Okay, take it, think about it, come up with some research ideas. Go to the next one. Anybody have a research idea they'd like everybody to consider in this world where AI apps are actually playing such an important role in diagnosis, prognosis, and in where to go for the best outcomes? Yeah.
We would still be testing the effectiveness and safety of these AI interventions until they're proven. And we will test the value of using the AI interventions relative to usual care.
Great. I know who might pay for your...
I'd be curious to know whether, so I have two comparators. So one is AI that originally was programmed by a human, and I would be curious to know if the inherent bias or implicit bias found in the human also translates to the machine's thought process.
Oh, interesting.
And then there's machine learning, where the machine learns things over time. I'd be curious to know if machines could then unlearn bias over time through a series of different simulations, they can figure out a way to maybe erase bias. That would be really cool.
Yeah, so I think you've just invented a new term too, machine bias. That's real interesting. Thank you. Okay, you ready for the next? Okay, now we're going into methods. Participant research using video, biomonitors, social analysis, and AI in 27 offers the best predictor for outcomes of health interventions. Want that again?
Yeah.
Yep. Participant research using video, biomonitors, social analysis, and AI in 2070 offers the best predictor for outcomes of health interventions. Think about that. Okay, anybody want to put ideas into the room on research? Yes, sir.
I think all these examples just get back to the core things that Cheshire's been doing around patient safety, quality and value. I mean, it's just, these are just new technology. I don't think it should be jumping on the bandwagon to do, but to be the voice of reason. And, valuation and the values of quality, value and safety seem to be ever more present, ever more important in this community.
Yep.
We were pondering whether patients could figure out how to game the AI.
Oh, interesting.
To get particular treatments they might want to get.
Uh-huh.
And how you could prevent that.
Human intelligence versus, and we'll see who wins, huh? Fascinating. Yeah.
So we were talking about as our measure of age changes from numeric age to biomarker-based age, like telomere length and things like that, how that will affect the research that we do, because most of our recommendations now are based on you start screening and stop screening at this age. So all of that will probably need to be redefined.
Yeah, so if you're thinking chronological age from birth versus a kind of physiological aging process, and it may well even be that I was talking with proteomics scientists that we'll have enough predictive ability on when you're going to die, so you could actually do age down from when you're dying, and from a research standpoint, different questions. Yeah, thanks. Okay, yes, sir.
I'm thinking it sort of depends a little bit about what you mean by health intervention that you stated. So let me just say, for example, if we were saying diabetes, and we know that lots of patient behaviors are important for optimal diabetic outcomes, and if we say health interventions, we might be narrowly defining that as the type of interventions coming from the healthcare delivery system, in terms of taking your medicines, et cetera. I'm making a little hypothesis here. But if we set things up from that perspective, then that leaves open that this data might help direct you to other, perhaps public health types of intervention. So if you find, for example, that a social network, which is kind of what I interpreted you saying, was highly determinative of, or predictive of, maybe not necessarily the right health behavior in terms of the compliance with the treatment regimen, then that would open up the question of, is there some public health strategy that you could attack that would help to move things along, because you can't necessarily assume that individuals, even with the Super Siri app, and by the way, Siri's not so smart,
I know.
is a complete solution. So the data would allow you to think about other, I think, public health strategies.
Yeah, that may actually be more powerful. Yeah, excellent. Good, good. Okay, ready for the last one? All right. The healthcare bubble burst in the 2020s, and across the country, hospitals sued patients into bankruptcy, leading to public outrage over the wealth accumulated by healthcare executives and doctors. By 2050, thousands of hospitals were closed, and most healthcare gets delivered in homes. Okay, any quick research ideas? Yes.
So we thought two things. First, we were concerned with the decentralization of healthcare delivery and the cost effectiveness of that. And then that would give rise to a whole new generation of medical technology.
Yep.
Because you can't drive a semi-truck with an MRI up to someone's house and plug it into their external power outlet. So I think to the point of the fundamental focus of Cheshire on outcomes and safety and effectiveness, I think would still apply. And then one point we talked about, because now healthcare providers are going to be in individual patients' homes, they'd have a much more keen understanding of the social determinants that may be impacting a person's condition or ability to participate in an intervention, because they see what resources were available in the home, they see the social network that person had to support them.
Great. Yeah.
So what you initially described as like the healthcare apocalypse, you know, and which degrades down to doctors going to your home, and effectively what happens is care only makes it to the people that have the most to give to the physician. So or any kind of care provider. So the research would be, how do we get care to everybody? Which is what we're doing now.
Which is what we're not doing now.
Well, no. Yes, Elvis, you are correct. We are not giving care to everybody, but we are doing research on that.
Yeah. The deep commitment to social justice still shapes the research agenda, and you're saying actually it would be needed more in given this forecast.
Right.
Okay, thanks. Yep. Yeah.
Well, we were just wondering, I mean, two suggestions so far have said doctors are going to the home. There's a whole telemedicine direction you could take this that would not involve, you know, Doc Baker from Little House visits at all, but would involve a whole new use of technology that was already named. So it's an interesting thing to think about, whether this would actually drive more of a wedge between the providers and the patients in terms of less human interaction.
Yeah.
Or could in fact facilitate interactions that we haven't had with our physicians, and perhaps even longer interactions than we've had with our physicians in quite some time.
Great
Yeah,
questions.
I know, but we're still not paying them with chickens like they paid Doc
That's
Baker.
very true. That's very true.
Chicken McNuggets, you get a... Yeah.
But new job opportunities. It's not the doctors going to the home, it's the robot technicians, right? And they'll have the face-to-face interaction with the patient while they're fixing their robots.
So thinking sort of past the present and then into futures, how many of you read Social Transformation of Modern American Medicine, Paul Starr's book? You may remember from that, historically, if you look after the Civil War, there were only something like 600 hospitals in the whole country, and that's where people went, and they didn't come back out. Yeah, you went with TB or with a mental illness, and you weren't expected to come back out. And then you got the modern American medicine in the 1990s, Mayo Brothers, 1,000 operations and people lived. And by 1910, there were over 4,000 hospitals. So thinking forward 50 years, could we see a reversal on that? And I think you've hit the key. If the technologies play that role, that could actually take healthcare back into the homes. Doctors used to go around by horse and buggy. This is a shift in the healthcare system in the new technology era. So I am going to tell you that in my work, oftentimes it's the expectable futures that get in the way of our thinking about where the real opportunities are. Albert and I were talking about Robert Wood Johnson Foundation. We did a series of scenarios back in 2012 to imagine health and healthcare in 2032. And we always use an expectable scenario, then we try to imagine things get desperate, and then what would it look like if we really got it right, if we were surprisingly successful. And between now and then, the scenario that looked most likely and expectable now looks a lot less likely than the most desperate scenario, health if you can get it. breakdown of our healthcare system, our public policies, the ACA. And so sometimes things do get a lot worse. But the most important and powerful is actually the ability to envision, what if we get it really right? And there we have now thousands of people who have dedicated themselves to this vision of a culture of health. And Robert Wood Johnson Foundation said, this is our vision. This is how our programs are going to align to support that. So this little bit of futures exercise is an invitation for you to think in the next series as you start to say, well, what should the research agenda be for Cheshire, to think about what if we could really get health and healthcare right, and our contribution to it was even better over the next 50 years, staying committed to that core with a deep commitment to social justice. So thank you for playing in the future space and being ridiculous with me. Jill?
Okay, well now we're going to do a little bit more in this space. I think, how many people felt a little uncomfortable having to be ridiculous? Anybody? Were people okay with it? I think what we find is that people want change, but people don't want to change, right? We don't want to personally have to be the one to do something different, right? But I'm going to ask you to do that anyway for this next part. I want you to do some idea generation. And for creativity, we've got to remember that what's different about us brings unique perspectives. That's my colleague Tyler from the National Center for our NCQA. And as you can see, Tyler is a male and I'm a female, right? Okay. He's kind of tall and I'm not very tall, right? He's young and I'm not as young as he is. So, but it's that together we can produce innovation because of our different backgrounds and our different perspectives, right? So we're going to be pulling you guys together again to work and brainstorm a bit. And you've got the intelligence, you brought it with you, so now you're going to have some fun, we hope, and that together is going to create produce some creativity. And I want you to try to allow yourself to feel a little excitement and a little wonder there, and think outside that box, okay? So out of your comfort zone, think a little bit outside of the box. And this is a picture that my son made when he was about 5. I asked him, oh, look, it's a tunnel. And he said, no, that's not a tunnel, Mom. It's not just a tunnel. He said, it's the tunnel to everywhere. And I said, wow, that's pretty good, right? For a 5-year-old, I was like, okay, Harvard, here we come. No, I don't know. We don't know. Right, Hopkins, here we come. I should have said that. But what I like about this is that I think about the tunnel to everywhere, and I think you guys right now, before we do this activity and before we go into our next 50 years, are standing at the front of the tunnel to everywhere, and you get to figure out what's on the other end. Where are you going, and what are we going to be doing over the next 50 years? So, ready, set, go. It's time to do a little creativity. So the first piece is that I want you, remember we've been talking about the methods, the policies, problems, issues, populations, or new organizations of the future, and then devices and technologies of the future. And you guys filled out some cards at the beginning, so we're going to use some of the ideas from those cards. But does anybody want to throw out an idea that they didn't write down on a card, or one that you did write on a card that you think is really exciting about the future, something that's going to be coming up that we all should be paying attention to? Something that you wrote down on a card. I wrote down virtual reality. What can we do with virtual reality? Who else put something down on a card or has an idea? Just anything, a method, a policy.
I'm getting old.
Okay, what's that, a problem?
Everybody else.
You know what? They say it's better.
It's a situation.
They say it's better than the alternative.
It's a situation, but I've got plenty of company.
Okay. So the aging of the population, I think, is what Albert's getting at. So that's one for sure. Kevin.
Take a tangent on that and say I'm getting old, but I'm still
Oh, yeah.
How does that affect health?
Okay, that's right, yeah. It makes us all sourpusses, is what it does, yes. Curmudgeons. Yes, Jody.
Huge data living in the cloud.
Right, huge amounts of data that are all there in the cloud. And sometimes we worry about all the data that's up there. Who knows what about us. What else? Anything else? Any other big, go ahead, Lily.
This is one I didn't write down, but talking about life expectancy.
Uh-huh.
How we go into college and all when we are, whatever, early 20s.
Yeah.
I think there has to be a way to repurpose and recycle people who live their lives till 60, 70 to again be able to contribute. So some kind of college of 60 or 70.
Right.
Because they have such a wealth with them. It's too sad that they are in good health but cannot contribute.
Yeah. So ways to tap into the wisdom of people as they acquire that wisdom and make sure it's getting back into modern discourse, not being forgotten or pushed away. Okay, all good stuff. So keeping your ideas hats on, we're going to do a brainstorming exercise where you get together with your neighbors again, and I was suggesting groups of 3, but just do what works in terms of numbers. And what you're going to try to do is come up with, again, possible research project or research ideas. The first thing is to come up with a research question, then a partner. Who would be the partners? Who would be the staff? Who would be the faculty? Who would you put on a project like that? The rationale for the project, and then some research activities, okay? And do take some notes. We are going to do a report out that Jonathan's going to facilitate, so don't get caught with us not getting your report out. And here's how you're going to do it. You're going to pick one from column A and 2 or 3 from column B as your starting point. And then I'll put back up the things you're supposed to talk about. Okay, does that make sense to people? Are people comfortable with the 1 from column A and 2 to 3 from column B format? So if you notice, what's in column A? Past Cheshire work. These are the roots. This is where we came from. And then, so you take something from where we came from, and then you add in a couple of ideas that came off the cards. And if we have time, we'll do more than one round of this. But I want to give you some time to talk about it now with your neighbors. Does everybody understand the exercise? Anybody wondering what I mean? Do I need to describe it again? Okay, we're all good. So ready, set, go. Put the charges back up if you're looking for what your categories were that you're supposed to be thinking about.
And you have about 2 minutes. 2 minutes to complete your charge. Okay, who can offer the first research project?
We chose primary care quality from the left column and sedentary lifestyles and long-term obesity from the right column. And our research question is,
what are the most effective strategies for primary care providers to improve outcomes and health habits for people with sedentary lifestyles with obesity?
so with that question, we wanted to partner with people in, like, I'm thinking of one healthcare system. So partner with providers, partner with folks like Apple Watch, with Apple, because that's one way to know whether it's a sedentary lifestyle or not. And of course have nutrition clinics involved, so it's not just non-activity, but also to know how much of confounding is because of bad nutrition choices. So that was the second. Rationale, do I need to provide a rationale? I mean, it's all linked. Primary care quality, sedentary lifestyle, and long-term obesity. It's almost like And what was the last one? I think research activities would be collecting data, both for the activity level, the nutrition level, as well as over long-term sample of patients that we have that come to these different providers to really know whether they are improving or not and know the comorbidities that they have. diabetes and hypertension, etc.
Thank you. Thank you both. Did anybody else have a primary care project? Okay, you had one? Okay, good. Was it similar in terms of the research?
Close enough.
Close enough. Good enough. Thank you, thank you. Okay, another research project idea. Different one.
All right, so we chose health manpower, which is a word I have never heard until today, and we decided it's health women and manpower. I'm used to calling it health workforce research, and we were looking at long-term obesity and sedentary lifestyles as well. We initially started talking about how we could use community health workers to address these issues, but then kind of backed up and realized there isn't a lot of work on just who is the health workforce that addresses long-term obesity and sedentary lifestyles. I don't think there is much in this space, so thinking about how we could survey various provider types, maybe community health workers, but also nurses and doctors, to figure out who identifies with this is my role and these are the things I do with it, and also talking to patients and seeing who they think should be helping them through these processes, to see where kind of the misalignment is and see if we could do a better job at equipping our workforce to address these pervasive issues in our society.
Great, thank you. You have time for one more?
I just wanted the microphone. So we chose the same kind of constellation of items from column B, the sedentary lifestyles, long-term obesity, and partnered that with devices, monitoring walking, blood pressure management, et cetera. But we looked at it from a healthcare financing viewpoint. And the rationale for that was that people who qualify for Medicare can be part of programs like Silver Sneakers. People who are fortunate enough to have private health insurance. Insurance companies are already providing some of those different lifestyle interventions. But there's a big slice of people who fall outside of that. And we were interested in what sort of healthcare financing models could allow a broader dissemination of interventions that we know work to address a group of people who have sedentary lifestyles, who make poor nutrition choices, who have these health sequelae. And in terms of partners, which is as far as we got, we were thinking, obviously, looking at HHS, CMS, large healthcare delivery organizations, but then in thinking, looking forward, partnering with technology companies, whether those be companies that produce wearables like Fitbit or Apple, or companies that create social networks for dissemination of information, and how that would be financed and sort of turned into the medical industrial complex.
Thank you. Thank you. Great. So Jill, are you content with the ideas you've gotten for a starter?
Yeah, no, for sure. So I thought there were lots of great ideas that you guys came up with, and I think what we've done here is just give you a taste, essentially, of how we can run this kind of an activity. We'll be doing this again at the research retreat in order to develop more ideas, and then at the research retreat we'll also have a prioritization exercise to try to pick some of these things and actually get started on working on them. And Jody Siegel and I will be planning the research retreat together, so if you ask her later, she may say, yeah, we're not doing that. I hope not. So let's turn it over now to Albert, who's going to take us through our wrap-up. And I just wanted to be sure that everybody knew about a couple of quick announcements. One is that going into the new year, we're going to be having a series of potlucks. And so that's for everybody to, again, camaraderie, happiness, enjoyment of each other, getting a chance to do some more cross-pollination of ideas and so on. So Lily Engineer is putting together a sheet whereby you can sign up for when you'd like to hold a potluck. I live down near DC, so I'll have a DC potluck, and there'll be some potlucks up here too. So hopefully everybody will sign up for that, and that should be a lot of fun. In addition to that, we want to remind everybody, take your souvenir on the way out as you leave. So we've got nifty mugs and sun catchers. And I think our last reminder for you is to please leave any notes that you took here so that we can use those notes in the upcoming retreat. But without further ado, let me turn it over to Albert for our wrap-up.
So I wanted to thank Jill and especially Jonathan for leading us in this post-prandial exercise. And the fact that people are still awake is a real credit to you. I feel like this was just really an appetizer for things that we could do. We have recently been discussing sort of trying to do more brainstorming to try to get at ideas, some of which might sound ridiculous or outrageous, but maybe some of those things are things that could wind up, if they survive, the evolutionary process could wind up getting us ahead. Thanks to Jill, too, for the reminders about upcoming events. And so, congratulations. Thank you to all of you for joining us for a big chunk of your day. And now we can say 50 years of Cheshire, check. We're done with that. A couple of people commented that they felt a little bit smarter about the center itself, including people who'd been in that center for some time, most of us less than 50 years. But also I think that looking at some of the successes in a way can, and some of our antecedents can really be instructive and maybe can help us look ahead. I have to show this photo one more time because it was, I'm afraid that Laura wandered off back to being a dean for the school. Am I the only one who thinks that Don Steinwachs looks a little like Spock? Yeah. But so in any event, this actually is this poster only reflects 40 years of the leadership of the Center in Health Services Research. This was actually developed for the last anniversary. But we are planning an annex for this poster to, I don't know if we should have, just sort of an appendix, or if we should have little thought bubbles that are inserted here and there that add some of the contributions, some of which in fact probably belonged on here, but I hadn't really sort of quite been aware enough when we produced this. More recently, we have been having an impact. This is our impact report, which Vadim and Ann Skinner are really largely responsible for pulling together. We've been doing this now for a few years. And perhaps the most important thing is that we've got about 25 or 26 core faculty and 30 affiliated faculty and another 30 staff. And this is a group that could do even more great things. So I'm looking forward to more activities in the rest of the year. So we're looking ahead. Jill showed some pictures of her offspring. So here's a young Wu. I would never let him close to any of the, I can't believe we actually let him get this close to some expensive optical device. It could have really turned out badly. In any event, we hope that this event provoked you a little bit, gave you a little extra energy, and perhaps planted a couple of questions in your mind. I feel a little bit smarter about the center and its history, and perhaps a little bit have some feelings about, gosh, maybe we should be doing more of some of those things we did, or maybe, okay, we've done enough of those. We can go on to the next thing. We are planning to have a retreat in which we will be more systematic about trying to figure out if we can come up with some joint direction. I think a goal of the center, this sort of ideal has always been to go back. Maybe this is just a bit of nostalgia, but in many ways, if most of us or many of us could work on something together, that would feel really good. Not to say that people shouldn't continue to do all the important things that they're currently doing. We hope we've managed to attract a few of you to collaborate with us, either anew or more than you have up to this point. And I would invite everyone here and the people who are here earlier and people who couldn't quite make it today to join us as we move forward into our next half century of the Center for Health Services and Outcomes Research. So thank you very much for your time and for participating. And I think we're actually going to end on time. Thanks again to Jill and the committee for organizing all of us, and to Mary and others for the mechanics. Thank you all very much.